Mute Mari Larry. Mute my baby. Why? It's okay, yeah, we can't help it. Yeah, yeah. I don't know who is listening to it. But can you listen to what I'm saying when you are with this? We are sitting directly. So forget it. We can't. We have to start. It's going to be 7 o'clock. I hate starting late. Bhagya, what's happening? All this have been done before. Leave it if you can't do it. Start
I have
admitting.
unmuted.
Yeah. And then start admitting because it's
My
already
audio is
7
heard.
o'clock.
Hello, can you hear me?
Can you hear me
Can you
now?
hear me now?
Is it audible?
Yeah, I can hear her, but it is very low.
Just
I
don't
think
do
I'm
anything
hearing
if you
over
don't
phone.
know. In the end. It's all be for
Can you hear me now, doctor?
I can hear you loudly from here.
I can hear. I can hear, ma'am, now.
I can hear. All of you can hear, no? Yeah. See, this is coming. It is echoing. Oh, okay. 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 Now admit people. Please start admitting people.
Can you hear me,
Admit
Gauri?
all.
Can you hear me? Okay, now I'm putting myself in mute.
Yeah. Put it in you. But where is my meeting? Okay, Nandini. But I'm not coming in. Why?
Yes, yes, doctor, we can hear.
No, but I'm not. I can't see myself.
No. Minimize this.
Okay. Deepika Jain. What is this? This stupid logo like this? Remove that. Okay. Okay. Can I start? Hmm? I don't have to make this big. No need. Huh? This picture is enough to be like this. Okay. Okay. Good evening, everyone, and welcome to our master class on The idea of starting this whole master class was to equip practitioners with knowledge to bring out the best in the children, to maximize the potential of every child and help parents cope with the problem the children are facing. That was our idea, and we are very overwhelmed with the response which we got. And we did not think with more than 10, 20 people will be interested, but we are overwhelmed with over 100. So we had to really pay for the Zoom meeting and get into it. Nevertheless, we are very privileged to do this for you all. And the TOTS guide and CCDD, we have been in this field for over 25 years. We want to share our experiences and how we have really worked ourselves out to maximize the potential. And I want to tell you, even during this COVID time, we could do so many beautiful online classes that we didn't have dropouts. We were able to reach out. So what are the tools you require? What are the skills you require is what we want to help you all with. And I hope this would be useful. This is our first meeting. We don't know how this master classes will go. We look forward to your feedback. And I also want to say, when I put this meeting out, we had a vast different kinds of professionals. There were physiotherapists, there were occupational therapists, there were pediatricians, there were developmental pediatricians, there were special educators, there were psychologists. Everybody cannot get everything in one master class. So we thought we sent out a second message telling you all, those who are interested. Today, we are going to talk about autism spectrum disorder and what all can you see in a child and how should you manage. Now, when we're talking about autism spectrum disorder, it is not just the three triad which you see. The child will have many other problems with it, sleep disorders, gut disorders, cognitive disorders, may have some seizures, adaptation problems, sensory problem, anxiety, depression, so many things are associated, and they will keep emerging. If our management strategies are not good, we'll again have them emerging as they grow up. That's why when you have adolescent and you have little older children, you and many of you have said, we don't know how to manage behavior. So we are trying our focus to help you all do that. And that's the whole idea. To do this, we need the help of the community, the family, and the professionals who are dealing with it. If we all are not together and understand what is it this child requires, what are all the problems this child has, and how we are going to address it. And of course, every time we have to keep parents in mind. How are they going to cope? How are we going to support them? Because their support is very necessary. I'm going to be very brief today. I'm moderating because I've got a wonderful panel whom all of my colleagues, and we are going to start with a case presentation with you all. And the case presentation is going to be with Dr. Akila. Dr. Akila is ready. Dr. Akila is just finished her fellowship with me in developmental pediatrics. She's amazingly done some good original work also on social emotional learning in children. But today she's going to see what is it you have to take a history and present a child with ASD. Akila, can you start?
Yes, ma'am. Thank you. Very good evening, all of you, and greetings from CCDD. So moving on to the case specifics, I'll be sharing my screen now. Is it seen? Yeah. So moving on to the case. So X presented to us at the age of about 2 years, 4 months with inadequate language development and inconsistent social skills. She was a firstborn child to a third-degree consanguineously married couple, and she had an uneventful birth and antenatal history. All her motor milestones were on time, and she used only single words with she had a vocabulary of about 50 words, but she did not use it for the purpose of communication. She stays with her parents and grandparents, and there is no significant family history. She has history of disturbed sleep. Her appetite is good, but she is a choosy eater. She is not toilet trained, and she was in the play group, but it was stopped subsequently as she was always on the move and she required individual attention and did not follow instructions. So to look at the clinical features as a brief summary, this is from the ADIR, which we use at the center. Her social behaviors were limited. She had difficulty in gaze modulation. There was no responsive smile, and there was a limited range of directed facial expression. Her shared enjoyment was nil. She did not enjoy in sharing behavior and directing attention, and she did not direct the other's attention towards an object or towards enjoyment. Her communication and gestures were limited, and her social interest in other children too was very little. And if anyone interacted, it was met with a negative response. The socio-emotional reciprocity was again very limited. She did not use gaze or vocalization in her social overtures and did not respond appropriately to interact with adults. Her imagination and play, again, her imitation skills were very poor, and her conversation skills was poor, with poor reciprocal conversation, and there was very limited to and fro speech. There was atypical speech with delayed echolalia. She had repetitive behaviors and her interests were very narrowed. There were stereotypic motor mannerisms like hand movements, and there was excessive interest in sensory part of the objects, and she liked the visual stimulus. So moving on to her examination, she was definitely overweight with about 15 kgs, but there was no dysmorphology, neurocutaneous markers, and rest of the examination was normal. So a diagnosis of autism spectrum disorder was made based on the ADIR, and further diagnosis tools will be briefed over by Dr. Kirtika. And the Mullen scoring that we use at our center showed a low functioning across all the domains. And another tool which we use at our center is SCOPE, which we are standardizing against the Mullins. And the SCOPE profile at the age of 2 years, 4 months showed that her functional level was very low. She was everywhere, all her domains of development was across 6 to 18 months. So this visual report would explain that a little better. This is a report which we all like to share because it's easy to explain to the parents as well and for us to know the strengths and weakness. So the green is something which is attained, orange is something which is emerging, and white is something that she's not attained. So if we see her functioning across the receptive, expressive, play, socials, self-help, visuospatial, imitation, fine motor, were all ranging in the 6 to 18 months functioning. So with this, the therapy was initiated, and almost for 1.5 years, she's received therapy. She was enrolled in our intervention program with 2 to 3 sessions per week, and she's on melatonin for sleep disturbance, and her sensory activities have also been provided. So with all this therapy, there's definitely progress, but her communication is now need-based. It's more so only with parents and her grandparents. She has functional play, doesn't enjoy playing with other children. She continues to have poor eye contact, imitation skills, echolalia, sensory issues, repetitive motor activities and speech, but she's now independent with her feeding and her toilet needs. So her current scope assessment at her age of 3 years, 9 months shows that her functional age is definitely improved. She's moved on to the next level, which is about 18 to 36 months. So we see that level 1 areas, which were initially white in the previous report, has now filled up and she's moved on to the next level. But coming to the areas which have circled, though her expressive language is improved, it is more so with her labeling skills, and rather than for the purpose of communication. We see that her imitation, play, social are all areas which are still functioning very low. An area of particular interest is her cognition, which is so much improvement, which is almost about 51 months. But if we look at it, it is not there in her visual, spatial, or a math domain. So another thing is whether this is a Saban skill and it is something to evolve, and a fascination for letters also, which I mentioned previously, is another thing. So with this progress, if I have to just summarize the progress that she has done, the areas of good improvement are in her receptive language, Fine motor, self-help, and cognition, which is almost so about 1.5 years improvement is there in these domains compared to her initial to the current functioning. But areas which are of limited improvement are her expressive language, social skills, play, imitation, where it's hardly ranging anywhere between 5 to 10 months. So, to summarize, we have a child who's been diagnosed with ASD, who's been on therapy with us for the last 1.5 years, and has shown very good improvement in certain domains and limited in other. So, there's definitely a scatter. But with all this, there are a few concerns which have developed. So, one is the fears. The fears have been there for about the last 6 months. It's on off to things which she's already been exposed to. So it starts all of a sudden and comes to an end, be it the therapist's phone, be it lights. So this aspect will be dealt with by Mrs. Savita, a senior therapist, in the next session, and her verbal rituals which have been developing. Any small disturbance in this ritual gets her very upset and disrupts the whole functioning. Though the parents are happy with her hyperlexic quality and a skill that she has, but this is something which is again coming in her way of further progress. And of course, one of the areas of concern to us is her weight gain. To start off with, too, she was definitely overweight, but she's gained about 11 kgs over the last 1.5 years. She has this behavior of eating the food that she likes in larger portions multiple times a day. So these are our concerns, and over to Dr. Nandini ma'am for further discussion on the same. Thank you.
So, what we really saw was this child, 3.5 years now, but came to us almost a year and a half. She's been on therapy with us. While you see, we are all very happy that the receptive expressive language improves. This is what we see most of the time. And I want to tell you something with parents. The child starts speaking. They think everything is achieved. They'll put them into school. They'll say the child will learn now. It may be just need-based communication, which improves. But parents don't know what is a functional language, what is the value of functional language, peers, I mean, social imitation. This child's, this limitation which Akila brought out in that scope. Now, scope is a profile which I'm going to introduce. The next speaker is Dr. Kirtika Rajaraman. She's a developmental pediatrician and an amazing developmental pediatrician, I should say. She has really, really done some original research on making this tool. This scopes, it stands for Social Communication Play in Education, is a criteria-based assessment tool which we have developed, and she's the main author of the tool. And why did we do this? We did this because we didn't know what was happening with our children. Yes, we say it improves. Where? Why? When it doesn't improve, why does these behavior problems and all sets into the child later? Have we missed something which we have not addressed earlier? Or is it the ones which we have to watch out? What will be the prognostication in the child? Will this child progress further? Will it go to school? Because it's reading, saying few letters. School is very, I mean, probably says, yeah, I mean, it can read. Parents says, I give words, it can read, but it is hyperlexia. It is really not reading. What is a relationship of cognition to the development of a child with autism? These are crucial questions you have to ask when you do an assessment, whatever kind of assessment you do. And when you get an answer, can you then make a program which will be worthwhile for you to see the progress? And then many times we say, oh, I have given therapy, my child is improved. What is the criteria? When can you say that the child has improved because of our therapy, or has it really outgrown? I mean, as the age grows, even without something, child will learn from the environment, or is it that? These are questions as a good therapist and a good organization we have to ask ourselves. How effective are we in our program? So I will now request Kirtika Rajaraman. Dr. Kirtika is, as I said, she is got a big insight. She's just not a developmental pediatrician. She has done play therapy. She has done ABA therapy. She has done NAME. She has spent time in NIMHANS learning child psychiatry, child psychology. I'm so, I mean, should be grateful and fine to be associated with her. And she did a fellowship with me, and I found that what an immense potential this girl has. And we decided we're going to work further and develop tools. And it's been a great journey with Kritika, and listen to her, and she'll be now telling you what should you do in an assessment, what all should you look for, and how does it go for an how to use it for an early intervention program. Kritika, are you ready? Yeah,
Yeah.
come.
Can you people see me? Hi, everyone. Hello. Can you people see me? I'm going to share my screen. Just second. Hope you can hear me.
Yes, ma'am.
Yeah, I'm sharing my screen. Just second. Hope you can see my screen.
Yes, ma'am.
Yeah. Good evening, everyone. Thank you, Nan, for such a introduction for me. So now we are going to look into what are the importance of assessments and why do we do assessments and how we are going to analyze the assessments. So the assessments in ASD, first we do it for diagnosis. So what a diagnostic assessment available is ADAR, CARS, and INCLIN. ADAS and CARS are observation-based assessment where the therapist or the psychologist observe the child and score the child on certain criteria, and then they fit in the child whether the child fits into autism diagnosis or not, and how is the severity of autism, whether it is mild, moderate, or severe. ADIR is an interview based assessment where the parents are asked questions over the child in the present symptoms and also the past symptoms, and based on which the child is classified under autism or not. Inclin diagnostic tool of autism is our Indian tool, which is also used for diagnosis. Now, out of all the four tools, ADOS is the most sensitive tool, and all the tools perform in the same specificity. So, is a diagnostic tool alone enough in ASD? No, the current recommendation says that it should be a part of a multidisciplinary assessment rather than a standalone diagnostic assessment. So, after making a diagnosis of ASD, what is the next important question from the parent is how severe is my child's autism? So, as explained prior, ADOS helps in knowing the severity, CORS helps in knowing the severity, and our Indian assessment, Indian scoring for autism, ISAA, also helps in scoring the severity of the child. What is the importance of knowing the severity? Just a second, my child slide is not changing. I don't know, it's getting stuck. Is it? I'm sorry. Yeah. Sorry, because of the graph, it got late. So when it comes to severity of us in ASD, is it going to help in prognostication? Most of the parents think, like, if my child falls under mild ASD or severe ASD, my prognosis is going to change. As such, a severity of ASD at the time of diagnosis doesn't matter much because over age the severity might change or severity might remain same. This has to be explained to the parent. So Gautam has put in a beautiful trajectory of autism severity. Severity can be persistent high for some children over age, or it can be persistently moderate over age, or it can be like the child started high severity, but over age the child improves and even comes out of autism, or can be worsening. The child started with a moderate severity or mild severity, and over time the child worsens. So while counseling the parents on severity, even if the child gets a moderate severity or a severe severity, where we are going to explain to the parents that over time and over therapy, the severity changes and it is not going to be the prognostic indicator. Then if severity is not a prognostic indicator, what is a prognostic indicator? So prognostication, the indicators are the nonverbal intelligence of the child, joint attention of the child, and motor imitation of the child. These are the three things which is going to help us understand a child at diagnosis, whether this child is going to improve or not over time, whether this child is going to stay in persistent moderate or persistent high severity, or the child is going to enter into improving severity. So, what is non-verbal intelligence? It's the intelligence of the child where the verbal component or the express language is not needed. The child is performing certain skills and showing his intelligence. So, the criteria is if the non-verbal intelligence of the child is more than 60 at the time of diagnosis, then the prognostication of the child is good. Next comes the joint attention. Joint attention, if a child shows responding to joint attention better, then the prognostication is better. Responding to joint attention mane, where the child can follow near pointing, where the child can have a little bit of shared attention. This shows that this child is going to improve faster. Last criteria is motor imitation of the child. If the motor imitation skills of the child is better, then the prognostication of the child is going to improve faster. So we are going to look into what assessment is going to replace this. So we have two types of assessment. Apart from a diagnostic assessment, we have two types of assessment. One is a norm reference assessment and a criterion reference assessment. For a norm reference assessment, examples are WISC, the scale of early learning, and Bailey. In this child, Muller scale has been done. For criteria examples are WILS, EMAP, ESDM, scope profile, and in this child, the scope profile has been done. What is the importance of norm reference assessment? It gives us the functioning age of the child or the IQ of the child. So if you want to know non-verbal intelligence of the child, we need a norm reference assessment. And what else it helps in? It helps us to know the ranking of the child in compared to other children of his age, so that we know whether the child is performing good or performing very low for his age. In criterion reference assessment, only whether the child demonstrate that skill, particular skill or not. Generally, you don't get functioning age in a criterion reference assessment, but the advantage of scope is you are going to get the functioning age of the child and also whether the child does the skills or not. It's usually a non-reference assessment measures the broad skill areas. That means you get the gross motor development, you get the cognition, you get expressive language, receptive language, social skills, broader areas. But the criteria reference assessment, you get a more specific skills like how the play of the child is, how the imitation skills, how is the functional communication, how is the self-help skills. So since it is more specific, it is better to use a criterion reference assessment for planning an intervention rather than a norm reference assessment. And another advantage of a criterion reference assessment is you can show the improvement of the child over time. A norm reference assessment only shows the where the child falls compared to other children of his age and not the trajectory of the child. So criterion reference assessment becomes important. Now let's look into the CCDD. We have devised our own criterion reference assessment scope profile. So I'm going to give a brief overview of scope profile. It is a criterion reference tool, and the milestone in this scope profile are developmentally sequence and is presented in three developmental level 1, 2, and 3. What I mean by that is level 1 milestones corresponds to a developmentally sequence milestone of 6 to 18 months. If a child clears level 1 milestone, first milestone, then the child's functional age is 6 months. If a child covers the 6th milestone of level 1, it means that the functional age is 18 months. Similarly, level 2 corresponds to 18 months. Level 3 corresponds to 36 to 4.5 years, 54 months. Now, what is the age group we can apply for? As earlier, criterion reference assessment doesn't have an age norm. It can be applied for any developmental delay child with a chronological age because it's a set of criteria or the milestones whether the child achieved or not. We are just going to make sure the child's functioning age is between 6 months and 4.5 years, and we can use this tool for any chronological age with a developmental delay who is functioning between 6 months and 4.5 years. We have proved the validity of the tool. It has a good diagnostic accuracy, and the content validity with Mullen scale is very good for this tool. We can assess 8 domains by the tool. The domains which are assessed by this are receptive language, expressive language, play skills, social skills, cognition, self-help, fine motor skills. So these are the 8, and the imitation skills. These are the 8 domains which we can assess, and each domain has a subdomain. For example, if we take into expressive language, it is not going to say the functional age as a whole. It will say in different subdomains. Functional communication. If a child is communicate for his needs, what is a functioning age for functional communication? Labeling and describing. For an autism child, the child might be very good in labeling, but his functional communication might be low. Questioning skills of the child. How's a child's speech production, structure, clarity of speech? So in each and every domain, there are subdomains where you get to know the child's profiling in detail. So how it can be tested? It can be directly tested on the child, or it can be an observed behavior. So in this COVID time, it can be a video observation of the child, or it can also include a parent's feedback. So this tool can be used as an online assessment tool also, and this makes an advantage of a tool. Any norm-based tool cannot be used as a online assessment because it should be only directly tested on the child. How's the milestone scored? It can be S, emerging or no. There is a detailed criteria for scoring this along with the assessment itself. So the time taken, it depends upon the level of the child. If the level of the child is level 1 and it's only 6 milestones up to 8 months, the child is at 17 months functioning age, then it might be only 10 months, 10 minutes. And if the child's functioning is at level 3, it might take up to 45 minutes. Now, to how we are going to interpret the assessment of this child. Now, as already explained by Akila, this is a child who presented at 2.4 years, and she had poor social skills, and she had language delay. She had a vocabulary of 50 words, but it is all more of a labeling vocabulary. What were the assessments done? A screening tool MCHAT was done. ADIR was done to confirm her diagnosis. She went into the criteria of ASD. Reference tool Mullen was done, and a criteria reference tool scope profile was done. So as explained already, now we are going to look into prognostication. How is the non-verbal intelligence of the child? How is the joint attention of the child? And how is the imitation skills of the child? Because if we have to counsel the parents at the beginning, we are going to look at these 3 skills and we are going to say the parent child false. Now looking at the Mullen's assessment, we should look at her visual perception, which shows a non-verbal intelligence. Her functional age is 19 months, which shows compared to children of her age, she is functioning very low and she falls under second centile. Now, if we have to calculate a developmental quotient, it is for 2 years, 4 months, she is functioning at 18 months. The non-verbal developmental quotient is coming somewhere around 62. So this child, as per the criteria, her non-verbal is more than 60, then this is a good prognostication factor. Now let's look into her joint attention is an important social skill. So under scope, her joint attention comes as 6 months and her imitation skills comes as 6 to 10 months. For a 2.4-year-old child, 6 months and 6 to 10 months is a low criteria. So one factor of non-verbal intelligence is going high for the child, and the other factor of joint attention and imitation skills are at a lower level. Now looking at a scope graph, so this gives a detailed explanation of how is a different expressive language. So subdomain is functional communication. And look at functional communication, it is as low as B means it is S, orange means it's emerging. So it is top P. 3 meaning she is able to function at the level of 6 to 10 months only at her functional communication. But when you look at the labeling skills, it is going as down as 8. That means she is able to do it till a level of 18 to 21 months in her labeling skills. When you look at her speech production and clarity, it goes down till the milestone number 9. It means that in these skill areas, she is good. But when you look at her social skills, there is no green at all. If you look at her imitation skills, it is only stops at milestone number 3, which is equivalent to 6 to 10 months. So for child, you have to get in the graph. This graph is prognosticating the child's severity of autism over age. Now, the IQ is 66, so she's falling somewhere over here, and the child has a possibility of taking the upper curve or possibility of taking the lower curve because her joint attention and her communication skills are on the lower side. I'm saying no possibility are there. If the joint attention and imitation skills are at a better level, I would say the child has a possibility taking the upper curve. Now, I'm going to say to the parents that your child is here, she has more option of taking this. With the early intervention, we are going to say which curve she is going to take. Now, let's go ahead. So now this child comes again at 1.5 years later at 3.9 years. Now, what is a prognostication which is needed at the review level? What I would like to see is generally when we are doing a review, it is necessary to do a repeat assessment of a criterion reference tool like scope profile, BMAP, or ESDM every 6 months, and a norm reference tool you have to do at least once a year. And a very important is at 4 years, you should have repeated. At 6 years, you should have done a norm reference tool. Why? Because based on the norm reference tool, you can do a prognostication. So what is necessary at 4 to 6 years for a good prognosis? Acquisition of a functional expressive language. The child should have acquired a good expressive language, and that too, should be used for a functional communication. If a child is at 4 years and if a functional communication is somewhere around 2.5 to 3 years, then I would say the child is progressing well. And another one is improvement in the intelligence of the child. So we have to see from the IQ level of 60, how much the child has jumped in. Because at 6 years, the IQ which the child reach is going to be the maximum IQ. And most is not going to be a child an IQ of more than 100 means that the child is an average IQ child. If a child's IQ is going to be some 60 only, then it fall under ED category. So improvement intelligence should happen, should start reaching exponential 4 years, and by 6 years it stabilizes. And what is the predictors for prognostication is repetitiveness, the comorbidities, and the sensory issues. Now let's look into our case. So in this child, we are looking into the score profile. We see that the cognition of the child at the beginning was 16 to 18 months, but as of now, cognition has improved to 39 to 42 months. That is, at the child at 3.9 years, her cognition is as high as 3.5 years. That means she is functioning very good in terms of intelligence. Now let's look into her scope graph. See, with scope graph, we have 3 components. One is the cognition, visual perception skills, cognition read, and cognition max. Now we look into her child T, when her cognition with respect to non-verbal intelligence is stopping at the level of milestone 10 itself. That means the child is functioning up to the age of 2.5 years only. But why is her intelligence coming 3.5 years? Because of her hyperlexic skills. Her C read is reaching highest sentient zone. That is, she's as good as a 4-year, 3-month-old child. So that her overall cognition age is coming as 3.5 years. But as such, if you look at her cognition, it stops at 2.5 years itself. So this actual cognition of this child is only 2.5 years. That means her intelligence is stopping at 60 itself. Now, when we are looking at the expressive language of this child, we have to look at the structural functional communication. If you look at that, the functional communication of the child is green till here, and here also there are some oranges, and over here, at 18 to 36 months itself, it has. Hello? Yeah. You can hear me?
Your voice is breaking, Kritika.
Yeah, Kritika, will you log out and log in again? And I will just summarize what you've been saying so far,
Okay, fine.
because, you are very breaking, so it's practically very difficult to listen to you. Okay, there are. What I want to tell you about what Kritika is been trying to tell you all is the criteria-based assessment which she was using is to tell you not just now. Many of you have got messages. We're using DSM-5 for diagnosis. It's fine. As we have said, severity of autism is not going to predict the prognosis. So if you whatever you all want to use, you may use it. But as we said, the limitation is not in the severity. It doesn't make a difference. Over a period of time, this severity, what you have done at the base, you can't explain to the parents that this is going to predict the prognosis of the child, because it does not. As we said, the prognosis depends on the other factors, like she said, joint attention, motor imitation. These are the skills which you have to look for. And in a criteria based assessment, when you do, you have to get these to predict the prognosis. And also, when you're giving the therapy, as she said, we need at least a 1.5 years or level of progress within the year. You are giving the therapy to say that we have made the difference in the therapy. And then she went on to say, what are the negative predictors? You see, when the child will develop comorbidities. But when Akila was presenting the case, she talked about, all the verbal repetitions, the repetitive functions, all the comorbidities, sensory comorbidities, all these will not be able to give you a prognosis of will indicate prognosis in the child. So you see how good your assessment should be. Do you all do an assessment correct, taking into account all this? It's then can you get a good picture of the child for you to plan an intervention. Is Kritika back with the Kritika, are you back? Yeah, just ask her if she wants to say. So she talked about this child who started, and she showed you how functional language was limited. The cognition had improved, and cognition has a good bearing to understand the prognosis to a large extent. But the cognition should not be because of a hyperlexia or other factors which we think is a cognition, but it stops that. For this child, actually, it was only at 2.5 years, though when you did the criteria and the parents and everybody thought because she can speak, she can say these words and she can read, she's highly functional. This is highly deceptive. So this deceptiveness is what you really have to. So this is what she was trying to tell you all. The value of doing a good assessment should be, you have to have a standard scale. We use Mullins because it's an early diagnosis and it's the only scale which gives you till 5 to 6 years of age. Others like Darcy stops at 18, before 30 months. The others are not, Bailey is not a screening tool. It's like any other tool. If you do Bailey assessment, it does not give you correlation to all the other areas. So what we validated the scope with the Mullins to see, and Mullins is also, and the other criteria tool, which is very, very good, is a VB map. But we cannot use VB map. It is the ABA therapists have to be, it is only they can use it. So that is what is the whole, uh, we talked about in the assessment. Please put your questions, each one of you, we will answer them. You can send us an email. I'm sorry the audio was not very good. Kritika is talking from very far and she's from a house, so I think maybe the connections are not so good, but we are back. Is Akila back? Is she with a better connection, or should we go ahead with the further? So what? So the gist of the whole assessment was, we
1 minute.
Back. Okay, Kritika, you're back. Yeah. Take over. Tell her to take over. Is Kritika back?
Yeah, I'm back. I'm sorry.
Yeah. Why don't you start with saying, yeah.
I'm sorry for being so audible. It's the internet connection. Hope I'm audible now.
Yes, you're better.
I'm audible nicely now.
Yes, yes, yes.
Yeah. So I'm just going from the case analysis part.
You'll have to share your screen now.
Sorry, the slide is again getting stuck because of the picture there and
Go ahead
internet
and finish
connection.
what you have to say. Don't worry about
Okay.
it.
So now for this child, T, her intelligence, though the scope profile shows it as 42 months, when we reanalyze it with the visual representation, it comes as low as 2.5 years. So her IQ is still around the norm of 60s only. It has not exponentially increased to 100. So at 3.9, that is at entering 4, she is still at IQ of 66. Now, when we come into the other criteria of the expressive language skills, her expressive language skills, when we look into the functional communication part, is still at the level of 18 months. So she has not made a much progress. So I would say this child is falling into worsening category. Now, like when we look into the negative predictors, this child has severity, severity to look at repetitive. This child has repetitiveness. Her concerns are repetitiveness. Her concerns are fixed interest. When we look into her repetitiveness, what are the repetitive behaviors which she shows is even in her labeling skills. If so, she starts saying a category. Now we are asking the child to sort a category. If she starts an apple, she will go on with all the fruits, and this is affecting her functional communication. This is affecting her cognitive skills. And now coming to fixed interest, she's so into the alphabets, she's so much into the hyperlexic skills that it is affecting her social functioning with the child. The imitation skills of the child has not improved a lot. So this variable improvement makes a child much more falling into a criteria of bad prognosis. Now this child, so for this repetitiveness and fixed interest, how we are going to address this? We can address it whether it's going to be a drug or a behavioral management. I would say she's 3.9 and it is better to address it behaviorally rather than through a drug. And another comorbidity she has is obesity. In a year's time, this child has gained around 11 kgs. Now, if so, we are going to give a drug like risperidone. This is going to increase the obesity of the child. Now, when it comes to obesity, again, we have to analyze in detail whether this obesity is because of a repetitive behavior which she shows in eating. And it's the only way of engaging with the family members, and the family members are also continuously providing with the child. Is that cause the obesity? Is it a repetitive behavior of eating continuously what she likes? Is it causing obesity? Or this child's IQ is on the lower range, and so an IDD is fitting in. It is IDD with obesity. With ASD, are we dealing with any genetic disorder? So after a detailed behavior analysis of this obesity, we should also think in terms of a genetic perspective. Now coming over to fears, I said in the when we are doing prognostication, there are three negative predictors. One negative predictor is repetitiveness, which this child have. Another negative predictor is a comorbidity. So look into the comorbidity parts. What are the comorbidities which can occur along with ASD in a 3 to 5 year age group? The yellow ones are the anxiety and the blue one is a ADHD. These are the two comorbidity which can occur at this age. Now, when we look into this child, she has a lot of fears, a fear for a truck sound, a fear for the chandelier, a fear for a mobile sound. Is it an anxiety or phobia which is setting in, or is it a sensory issue? This also makes us think more into behavior analysis before looking into it as a comorbidity. So this child, when we analyze it with respect to assessments, it falls into a bad prognostic. Lot of bad prognostication signs are there. So this child needs a detailed behavior analysis before addressing it as a comorbidity, before addressing it as a obesity genetic component. Thank you.
Okay. Yeah. Uh, Thank you, Kritika. Please send in your questions and queries, but now we have to address the behavior part. Now I'll call upon Savita, who is a therapist with us. She's an MSc in psychology, and I must tell you, Savita is like my right hand. 25 years she has been with me, and we have learned both developmental pediatrics, therapy, understanding together. So with 25 years of both of us being together, we try to crack as much as we can do with this subject, which is so difficult and so challenging. I can't tell you all. So I'll ask Savita to talk about what behavioral challenges she faces with this child and how are we really, really going to help this child. Savita, can you start?
Okay. Hi, everyone. Hello. I'm in the allow people. You have to speak into this microphone. Yeah, I have this microphone here. It needs to go to this. Okay. Just hold it. Just hold the sentence. Okay, can you hear? Okay. Hmm. Okay, so we need to learn about the behavior now. So behavior is very common to all human beings, right? All living animals and birds and human beings also show behavior. Then what is the behavior? Behavior is a response to internal and or external stimuli. Okay, behavior is learned through our past experiences, and we learn the behavior, and it gets strengthened when it is behavior. Then what is the behavior? Go to the first slide, please. Behavior is a response to go to the first slide. Yeah, can I operate? Yeah, it is learnt, as I said, and behavior is a tool for communication. Behavior can be verbal or non-verbal. It can be shaped or it can be modified by using principles of positive behavior support. Can I operate? Yeah, it is learnt, as I said, and behavior is a tool for communication. Go to the next behavior. So when it is very common, behavior is seen in everybody, then why do we call it as challenging behavior? We call any behavior as challenging when it is not age appropriate or when it is not socially appropriate, when it interferes with the learning of new skills, self-injurious or injurious to others, and occupies child's attention. That's why we call
Excuse me,
it
ma'am.
challenging behavior.
Excuse me, ma'am.
Can you hear?
Excuse me, ma'am. Sorry for interrupting.
Interferes with the learning of new skills,
Hello.
or injurious to others. Commonly identified.
Excuse me, ma'am.
challenging behavior.
Excuse me, ma'am.
Commonly identified
Excuse me, ma'am. Sorry for interrupting.
unwanted behaviors are very nicely explained in our scope program, that it is
Your
non-consensual
voice is echoing a lot. So, can you please check on the sound?
hyperactivity, poor articulation, poor generalization skills, difficulty in transition, defective imitation and visual perception skills, and sensory defensiveness.
Your voice is
So,
echoing a lot. Can you please check on the sound?
poor articulation, okay, poor generalization skills, difficulty in transition, defective imitation and visual perception skills, and sensory defensiveness.
More useless, right? She will just write. It is this.
So the main four functions of behavior are okay, the main four functions of behavior are attention seeking, task avoidance, tangibles, and sensory issues. How do I go to next? Okay. So So what do we use here? We use ABC technique taken from ABA. So when we know the setting events, which are mainly physical, physiological, or environmental, and if we know about antecedent, that is preceding to the behavior or the behavior itself, and the consequence response to the behavior. If we know this, it is easy for us to analyze the behavior of the child and give a proper strategies, because setting strategy for setting events is completely different, strategy for antecedent is different, setting for consequences behavior consequences different. That's why we have to identify e- problems at each level. So here in our center we use PBS, that is positive behavior support. The principles of positive behavior support and what we collect in positive behavior support are, how to go to the next slide. Okay, so we need to describe the unwanted behavior reported by parents, because parents spend lot of time with children. So we have to take their concern and we have to get the report from parents mainly. And we have to also identify in the classroom what happens. And we have to gather frequent data, which includes frequency, duration, and intensity of unwanted behavior, and time taken to respond during behavioral problems. And we should also identify the function of the behavior, attend the behavior immediately if it is very severe, like lot of self-injurious behavior or injurious to others. Otherwise proceed with the developmentally appropriate plans. And what exactly the previous slide please, the reward only appropriate behavior and ignore inappropriate, but don't ignore to store the data. You should always collect the data. So in when we take this index child, okay, let me give one simple example so everybody will understand what exactly is this setting event and ABC. Say I have a child who comes in the afternoon for the session, and child is forced to the session where the other children, cousins and all, playing and watching TV in the at home, and this child is forcibly brought to the class in the afternoon, that is sleeping time of the child. And at the same time, mother brings and drops the child to the classroom, and she says bye bye and she goes. The child thinks mother is leaving, so she will start crying and she will start puking also, and immediately mother is called inside. In this situation, child is sleepy in the afternoon and other children are playing at home, will be the setting event. So many setting events you can see here. And the antecedent is, child mother comes and drops the child to the class, and she says bye. And consequences, I mean, child behavior, challenging behavior is child starts crying and she starts puking. The consequences, therapist will allow the mother inside. So like this, when the challenging behavior is reinforced by giving mother's attention, it is easy for the child to cry or puke or do any other tantrum behavior, so that she, instead of just calling or requesting mother inside, she gets the mother inside. So it is very easy. So it, as I said before, it is always depends, behavior depends on the three other factors, like setting event and antecedent and consequence. So we need to focus more on this. So but in this child, the index child, the three major unwanted behavior that we have identified is fear. The child was exposed to lights or the vehicles or whatever. All of a sudden child started crying, and it went to that extent the parents have to stop bringing the child to the session. So parents started avoiding bringing the session, and somehow it got um, uh, you know uh, the fear went on. So here, before we would train the parents about setting events and ABC factors, this has happened because parents were not knowing this is an unwanted behavior. This can be attended by taking professional help. So here we understand, is it a sensory issue that child has developed fear and it just vanished without attending. And the second major unwanted behavior we have noticed is overeating. Overeating means the child, earlier it has been said, like, the child is very picky eater. But how contradictory child is eating, overeating is, like, whenever parents sit to eat, the child will come to them and she will also start eating. What parents are thinking, child is asking, so they can't stop the child, they are feeding the child. So this is happening because of poor imitation skills. What the other children are doing, are the other children also sitting and eating? No, they are doing something else. Because this child is having poor imitation skills, this child is not understanding what else he can do. Or inadequate social interaction and initiation, she can go and play with other children, but as she has got poor social interaction and poor imitating skills, this overeating is being reinforced by the parents. And as mentioned earlier, repetitive and ritualistic behavior can be seen in this child. She wants to repeat whatever object she knows. She will start naming the other associated things, because again, she is not taking language modeling and all. She is not imitating what parents are doing. If they take any fruits or vegetable, are they stopping at one name? Are they repeating the whole 20 fruit names and fruit vegetable names? Because of this repetitive behavior, child is losing social skills. We cannot put this child in the group and all. This is what is happening. So this can be identified as unwanted behavior. Next slide, please. So the strategies what we have used here is educating parents about positive behavior support and counseling the whole family to be consistent in their approach. Because here in this case, mother understands everything and she tries to go home and tell other parents how to tell other family people how to work with the child. But they think when child comes to the plate, and if it is not given, child will lose the opportunity of eating. So the whole family should be counseled that food is not the only social interaction or something. They can help the child to communicate the needs properly verbally. So constant review with medical professionals for further guidance is suggested for this child. We have very good professional support here, like Dr. Nandini, Dr. Kirtika, Dr. Akila, Dr. Gauri. They are all helping us in helping this family also. Explain. Yeah, thanks a lot. What I want to conclude with is, children forget what you told them, but remember how you treat them. So please treat the kids with empathy and proper guidance. Thank you all.
Okay. It's so difficult to do a topic like this. Hey, where is me? Huh? Unmute myself. Okay. 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 So thank you, Savita. So what we saw today was a case which came to us. We are in therapy. Even after 25 years, we are still at a loss. Why should this child, who was very comfortable going into a room with light, suddenly develop fear for the chandelier in that room? She was in and out of that room, but the minute she sees a light on, she'll start crying. And the chandelier, whether it's off or on, she would see a truck on the road, she'll start crying. If she sees a picture of a truck, she starts crying. I mean, showing temper tantrums. We don't know. It's so bizarre. We're trying to figure it out. What is the antecedent which is precipitating this? But it's so sudden that we are not able to find an antecedent. So we are still at a limbo as to how to really, really counsel these parents. Overeating, we are to some extent we have figured out, and we are trying to tell them that don't eating is not the only thing. Now, if it is limited to us to the that is this child going on to an anxiety status, and anxiety status is a first kind of a psychiatric overlay, and Kritika showed you those slides which will set in. So if you need to do a very good barrier behavior assessment in a child when you have autism, because you cannot predict all this and prognosticate all this, some people, some of the questions which have come to me is, what is the upper age for a scope limit? There is no upper age. It will give you developmental age from 6 months to 5 years, more or less like 4.5 years. So that you will get the child functioning within this area, and you can make out the severity, you can make out the imitation skills, whatever it is. Preferably we use it for maximum about 8, 9 years old children. We have other things to do when their children are older. So that was one question which people kept asking me, and we told you again and again, severity of autism is not a prognosticating indicator, and a good assessment and a good uh, intervention can be only planned if you know what to do. And second thing is, your intervention strategies have to be what the child needs. For us, we will focus on this child a lot and still trying to work on her imitation and social skills, understanding her better rather than her doing hyperlexia and cognitive. Of course, we tell the parents it's good. We don't underplay. We underplay that and say it's good, but she's not going. We constantly keep telling them this has to improve the child. Otherwise, it's going into a status where it's going to become plateau now. Her prognosis from now onwards is going to be very, very limited, and it's worrying us a lot in this child. And so this is what we wanted to tell you, that it's not easy to manage. You would have to require a good understanding. Now, of course, how a team is important to manage a child. We do, of course, looking into what genetic factors. Are we going to analyze anything? If the parents are not agreeing for a genetic analysis, they are saying what big deal is going to happen. Not that they are short of money. They're extremely well to do. And incidentally, behavioral problems is more seen, especially aggression, they say, in a higher income group than in a lower income group, for whatever reason, some of the papers which I've been reading. And of course, the IQ of this child is bothering us. We are really struggling as to how to manage this child's anxiety as well as her fears. But fears come and go, so we don't know what will happen next. So this unpredictability of a fear is really, really a worrisome factor. Nevertheless, they were getting somewhere with the mother, but we don't have on board the father and the grandparents. They don't allow us to tell them that don't do this. They don't agree. They think the child will grow out all this and learn. So this is a good place for you all to do a good analysis, good case workup for you all to understand what all you will have to face. And if you have that, probably you can figure it out, some strategies which you can work on yourself. So we'll take in a few questions if you all have, and uh, yeah. Yeah, there's a lot of question about people asking me for the scope profile. Scope profile is very simple to do. All that is there is you need the kit. It is like doing a dasi, it's like doing a Bailey. Everything is very specific. We'll tell you item number 463 for assessing this or whatever. It's a huge kit, which is, it's quite a lot of the kit can also be used for intervention. It doesn't come as a cost. You have to buy the kit, which is 12,500 rupees. And to get a profile, you have to pay TOTS guide 500 rupees to get the profile. You can charge what you want for assessment. For example, now in our center, we anywhere between 2,000 to 1,500, or depending upon the income of the child. But we have to pay 500 rupees because it's an online tool. You can't do it offline. Everything you have to enter, and the graph, everything will come online, and it is stored for you in the cloud, so that when you repeat after 3 or 4 months or 6 months to see prognosis, you will get the this thing. Yeah. I'm sorry about the voice clarity. That is really, really not in our hand. It is technology, which is this thing. And how do you manage sensory problem in scope? We have that is done by the occupational therapist. Scope stands for social communication, play in education, which is the sensory part of it. If it is there, you have to take a help of a sensory therapist. We don't find that as so much major problem in younger children. We can figure out sensory therapies more easily, but it is programming the parents, and this is a parent based intervention tool, because the intervention which comes for it is specific. Suppose your child is functioning in the imitation at 6 or 8 months, you will get intervention to develop that for that level. Suppose your language child is at 2 years, you will get language at 2. So the profile, the intervention is based on the profile, and it's a parent based tool. Parents get activities in the house, and some other time we will is there there is a score. You can make out the level of functioning, isn't it? For a non-verbal intelligence, there is. If a child is 3 years is functioning at 6 to 8 months level, what is it trying to tell you? That is the prognosticating indicator. It is all fitted into the criterion based tool. If Kritika, you want to add anything, please add, for this thing. So this is a tool which is, we have got quite a few people using it now, and they're very happy, and we handhold you all in the tool, even for programming, and also helping you all. They're saying, so individual questions I may not be able to answer. Please put it. Anxiety is a big status unless you give me the setting event, the antecedent, what is a verbal, what is a consequence. How can we give you an answer for a child who is crying, at 3 years? So you need to know the whole talk on verbal behavior was to identify what is the reason for that. So the reason is you have to know at least the setting and the antecedent. Antecedent is something which happens just about 30 seconds to 1 minute before the child problem behavior. Setting event can be anything. It tells you that this is the reason, but the immediate antecedent should happen between 30 seconds to 1 minute before the behavior occurs, and that is what is called as antecedent. So unless you have all that, it is difficult to manage a child with any behavior problem, and yeah. Yeah. So if you want more information on, please write to support@totsguide.com, which the organization will send you this master class. So they will be able to help you with, if you want to know more about the scope assessment, intervention, and how it works, and what is it, and you can get trials of it, and all those things are possible, provided you all write a mail to us at support@totsguide.com, and we should be able to help you, for training is available. Cost is, as I told you, just a kit, and you can keep doing. Every time you do, you have to pay 500 rupees to the to TOTS Guide for giving you the profile which you generated. Training for doing scope is very much possible. We're also, I mean, we have trained quite a few people, and now quite a few people are using it, many in Karnataka, Tamil Nadu, and all, and they're pretty happy that they're able to manage. And if you have any problem, we handhold you all as to how to do it. And what's also amazing from scope profile and the scope intervention is we also have a social ABC element in it. What is social ABC is training parents on how to be an interactive and direct training techniques. The parents have to learn techniques to work with the child, whether it is behavior, whether it is. So that also is a part of our scope intervention program, which for every activity we suggest what kind of technique the parent should use, or the therapist can suggest to the parents to use. So this is the whole, so sort of, we thought of, we put this webinar to tell you all, firstly to tell you what are the complexities in a developmental, and any development you take is not in isolation. A cerebral palsy child will have communication problems. A IDD child will have adaptive behavioral problems. So you have to have a good knowledge to manage this. So I'm going to conclude today's this thing. If any doubt, any queries, please write to us. We will answer. The technology sometimes does not allow you to, for breaking up voices, not hearing is really, it's bad weather, sometimes probably raining in some places, and we are not able to help that. Thank you very much, and good night. And if you all have to send me more feedback to say, is these classes useful, and should we continue them over the next few months, focusing on, we have very interesting thing to tell you about learning disability, attention deficit, and so many issues which these children, how do you understand them, would be our focus. And if you're all interested, get back to us, and we'll be very happy to help you. Thank you very much. So we'll call off the meeting. I think this is, those of you, I don't know how good it is, but it is available on the YouTube also. You all can, if you couldn't hear it very well, please, we did try to stream it through the YouTube. I don't know how will clarity be, but you all can see it. Thank you very much. Good night.